My name is Daniel Luksic, and today I'd like to present on an article called A Computable Phenotype for Autosomal Dominant Polycystic Kidney Disease. This paper was written by researchers from the University of Kansas Medical Center and was published in 2021 in Kidney 360. Autosomal dominant polycystic kidney disease is one of the most common inherited kidney diseases, and in about half of people affected by it will progress to end-stage kidney disease. This diagnosis can be established via genetics, although this is limited by a number of factors, including variant interpretation, and the diagnosis is usually established via imaging, specifically ultrasound, which the authors consider to be the most sensitive measure. Whenever patient medical records are stored in an EMR, it may be possible to identify patients via a computable phenotype, which is when clinical characteristics are extracted automatically from the EMR. This paper uses a computable phenotype to identify patients with autosomal dominant polycystic kidney disease from their ICD10 codes and evaluates the performance of this computable phenotype. This study tested the accuracy of the computable phenotype in 4 groups of patients, stratified by those who either were or were not followed by nephrology and those who either did or did not have a diagnostic code of ADPKD. After the computable phenotype classified patients, reviewers then manually checked each patient for clinical diagnostic criteria and then calculated the sensitivity, specificity, negative predictive value, and positive predictive value in each of these 4 groups. There were around 535 patients in each of the followed by and not followed by nephrology groups, with each of these groups subdivided about evenly into those with or without ICD-10 codes for ADPKD. Overall, the computable phenotype performed pretty well, with a sensitivity of 97% and a specificity of 82%, which the authors considered to be underestimated. Looking at the results from the perspectives of the patients who were reviewed to either have or to not have a clinical diagnostic criteria of ADPKD, the computable phenotype performed very well, with only 3 false negatives and 47 false positives, showing that the strength of the computable phenotype was really in having a very high negative predictive value. The authors judged that the computable phenotype for this group of patients was excellent in the NPV and the PPV was acceptable. Patients who were followed by nephrology shared higher performance characteristics across the board, suggesting, unsurprisingly, that nephrologists are better able to classify kidney disease than are other providers. The computable phenotype's high NPV and middling PPV suggest that this is most accurate in identifying patients to be ruled out of having ADPKD and less accurate in confirming a diagnosis. Finally, the sensitivity and specificity of this test compared pretty favorably compared to other computable phenotypes, such as that for acetaminophen toxicity, myocardial infarction, and cerebral vascular disease. As for the limitations, 34 patients with inconclusive results were excluded from the analysis. Also, the Kansas University Medical Center is a PKD referral center, meaning that the higher institutional knowledge may have inflated the computable phenotype's test performances. This illustrates the conclusive diagnosis, including genetic testing, still has a very strong part to play in establishing a diagnosis for patients suspected to have ADPKD and for informing their care. Thank you very much.